Welcome to today's webinar, Telehealth Response to the Pandemic in Rural Hospitals and Clinics. This telehealth webinar is the second of a six-part series for fiscal year 2021, focused on rural telehealth topics to build state Flex program knowledge and understanding of the use of telehealth and the response to the pandemic in rural hospitals. Our speaker today is Dr. Corey Skurlock. He is a critical care physician with a deep background in acute care telemedicine, starting his first program in 2011. He is the CEO and founder of ECWM, a telehealth-enabled provider organization, growing it from its original hospital to over 30 health systems, hospitals, and post-acute facilities across 15 states. Prior to starting ECWM, he served as medical director of eHealth at New York Medical College, where he designed, implemented, and directed acute care telehealth programs for ED, ICU, med-surg, and stroke, through which his organization was awarded the highest ranking in quality in the nation for 3 years in a row. Prior to becoming involved in telemedicine, he was the director of the CVICU at Mount Sinai School of Medicine in Manhattan. Dr. Skurlock graduated magna cum laude from Texas A&M with a degree in chemistry. He completed his medical school education at the University of Texas and an anesthesiology residency at Baylor College of Medicine, in which he was elected chief resident, followed by a critical care fellowship at Harvard Medical School. In 2010, he completed an MBA from the Johnson Business School at Cornell in Management and Leadership. He is the author of over 70 peer-reviewed publications with articles in the New England Journal of Medicine and Circulation. And so with that, Dr. Skurlock, I will share your slides and turn it over to you.
Oh, thank you, Nicole. Thanks for the very nice introduction. And I really appreciate the audience. I'm very happy to talk about this as a topic near and dear to my heart. I'll get into this from a rural area myself. And so, being able to speak on this is really, something that I'm very passionate about. So if you don't mind just forwarding to the next slide, please. We're going to talk really, some trends in care. I think they're not particularly, delightful to bring up, but there's some things that COVID has brought to light and really how it's affecting access and quality in our healthcare environment. I'll tell you a little bit about my journey and how I got here. And then we'll talk about ICU medicine just in general. And then we'll talk about tele-ICU and what it can do and what it can't do and how it can really accentuate hospitals, not only quality, but also their financial impact. And then we'll turn it over for discussion. Next slide, please. Typically, I do 3 objectives, but I knew this was a really good crowd, so I put 5 out there. We're really going to talk about how tele-ICU works and how it can support rural hospitals. And it's got in there during the pandemic, but really all this can occur before or after the pandemic too, so don't get focused on that too much. And we'll talk a little bit about how keeping the patients local is really good for both the patient, the hospital, and the clinician. We'll talk about provider satisfaction with telehealth, and then we'll talk a little bit about quality and then how state Flex programs can really support tele-ICU in their local environment. So next slide, please. 2 trends in care. These slides are pretty ominous when you think about them, but they're what's really going on right now. The first is that we're at a real tipping point with providers and nurses and clinicians in general on burnout. And what we found during the pandemic is the frontline worker was heavily exposed in the hospital space to COVID-19. And what this did is it led to a lot of healthcare workers choosing other fields. If you look, about 18% of all healthcare workers are leaving or considering leaving the field. This puts backward pressure on those that remain. The other 82% still have to do all the work, which creates a lot of burnout. If you look at burnout, it's heavily associated with overload and night work. And with people leaving the field, obviously these both get worse. If you look, I saw a recent study showed that from the American Association of Critical Care Nurses showed that 2/3, 66% of critical care nurses are thinking about leaving the field. We need those frontline workers, and reducing their burnout and bringing joy back to their work is critically important for our healthcare system. So we need to find a way to do that. Next slide, please. The other thing I'm going to show is really the financial impact that's going on right now. Hospitals are having very high acuity patients. That's due to a number of factors, whether that be the aging population, COVID, or just the fact that a lot of patients who had acute conditions didn't get treated during the pandemic are now coming to the hospital in a much more sick state. So what that's done is that's driven up length of stay quite a bit. And that impacts both variable and non-variable costs in the hospital. But where it's driving up costs the most is really around labor costs. And if you look at the use of locums physicians or traveling nurses, that really drives up hospital labor costs. And right now, a third of all hospitals have negative margins or below the black line. So we need to find another way to take care of these patients and do it in a cost-efficient manner while also minimizing the impact to our staff. Next slide, please. How does this impact rural hospitals? So right now, 1/4 of rural hospitals are at immediate risk of closing. And that's really that top right graph with the pink areas. Those are the hospitals right now that are at immediate risk of closing. If you move down to that bottom graph, you look at the pink and the purple, those are where states that are facing hospitals that are not at immediate risk of closing, but most of the revenue for the rural hospitals is not occurring from patient-driven care. It's actually from things like local state taxes or subsidies or grants. So they're not at immediate risk, but they're at long-term risk of closing. So we're at a real critical inflection point with the rural hospitals and what they're doing financially. Next slide. So rural health and telehealth, they sort of combine each other, but they weren't always that way. If you look for the last 10 years, telehealth prior to the pandemic was growing at a 300% annual rate. It was already really growing pretty rapidly, but most of that growth actually was in urban areas. It wasn't in the rural areas. With the pandemic, we think we took a 10-year jump in terms of adoption of telehealth in 1 year, now probably even further in the 2 years of the pandemic. And hospital systems, particularly rural areas, really had to embrace telemedicine relatively rapidly and implement it on the fly as they were dealing with these surges of patients. I think now there's an opportunity to take all that good work that was done and refine it and sort of implement best practices and really try to drive change in the rural hospital environment because they can really benefit from it. What we've also seen is that patients really like telehealth. When you survey them, they're universally positive. Actually, older patients are the most positive because they find it the most convenient. And so there's this real moment where reimbursement's changed and it's moving towards more telehealth reimbursement. There's now some changes in the state licensing where there's reciprocity across state lines. We're moving towards easier telehealth implementation. And so we're at this real inflection point with telehealth and rural hospitals, and we should really try to take advantage of it right now. Next slide, please. A little bit about me. I grew up in a town called Gladewater, Texas. For those of you who don't know, it is the antique capital of East Texas. It is about 2 hours from any major city. I want to say the population is 6,000. 30% of the population lives below the poverty line. The median income is about 29,000 annually. So it's not a wealthy area. Certainly to get to a major hospital for us would have been a 2-hour drive to a tertiary quaternary care center. Unfortunately, that's just not unusual, not in Texas and not across the United States. And so this is an area of real passion to me. When I started getting involved with telehealth, it was really trying to make a big impact on the US healthcare system, more than I could have as an ICU director. And so, having this opportunity to speak to you guys, I'm really excited by. Next slide, please. So let's look at ICU care. Let's zoom in on ICU care and what it means in the country. So if you look at ICU care, or intensive unit care, it is where the highest acuity patients in the hospital are. It's the place where the most hospital complications occur. It's also typically a bottleneck for hospitals, meaning it's a capacity constraint. What you find is that in healthcare networks is that the mothership hospital is often overloaded with ICU patients, and there's even lower acuity ICU patients that probably shouldn't be there. And then at the community level and the rural level, the ICUs are relatively empty and underloaded. And so this is an opportunity to redistribute these patients and make sure that the right patient gets the right care at the right time. Next slide. If we look at the US, there's about 6 million ICU patients annually. The predominance of those patients are going to be over 65. We'll talk about that in the next couple of slides. That care consumes about 1% of GDP. And that statistic's about 20 years old. It's probably closer to about 2% of GDP now. So it's a real cost burden for the United States. Even though there are about 94,000 ICU beds across the country, they make up about 15% of all hospital beds, but that 15% encapsulates 30% of the cost occurring in hospitals. So it's a very high cost area, very highly utilized area, and it's largely driven by the aging population. Next slide. We've known now for 20, 30 years that having ICU specialists in the ICU can really reduce mortality, reduce length of stay, lead to better patient satisfaction. This has been studied over and over. These are two of the major articles in that. However, when you actually survey and sample most hospitals, there's really two levels of care. There are the patients. There's a level of care that occurs Monday through Friday during work hours, where there's a lot of staffing around, a lot of decisions are made, a lot of resources to bring to the patient. And then there are the nights and the weekends. And in the nights and the weekends, there's relatively less staff, there's less resources, and many ICUs they're not quite ghost towns, but they're not very inhabited at night. And so the patients really are expecting 24/7 care. If we're going to drive down costs and drive down length of stay, we need to be taking care of patients 24/7. Hospital administrators really would like 24/7 care. Payers would like 24/7 care. And so the real trick for the next 20 to 30 years, as we're dealing with the aging population, is how do we bring that 24/7 care to these critically ill patients? Next slide, please. And so we are at the beginning of a supply to demand mismatch with ICU specialists. And we've known this for the last 20 years. COVID accelerated this and maybe exposed it to people, but it's been a well-known fact. And really that was the genesis of teleicu when it was first born 20 years ago, was that we're going to face this lack of resources, and how do we deal with it? How do we use technology to deal with it? If you look at what drives ICU utilization, what's driving the increased ICU utilization, it's really the population over 65, the aging population, which tends to live more in rural areas than urban areas, by the way. So when you turn over 65, you actually start utilizing the ICU at about 3 times the rate. When you're over 75, at 5 times the rate. And when you're over 85, at about 6 to 7 times the rate. This comes out of congressional workforce reports from about 15 years ago. So that's what's driving the demand for ICU resources. What's really driving the supply? And there's really 2 factors driving the lack of supply of these intensivists. The first is burnout. ICU work is heavily associated with burnout. It's high stress. It's not particularly high reimbursement for physicians. There's lots of night work. And like I mentioned before, night work's associated with burnout. And there's lots of ethical issues that really burn these physicians out. So if you look at the typical retirement age of an ICU physician, it's about 55. So it's a relatively short career. On the flip side of that, if you look at the trainees coming out of programs, they don't choose critical care medicine as their first choice. As I mentioned before, they see it as very stressful. It's not the highest paying field, so it's not attractive from that standpoint. It's 24/7. They want their rest. And they see a lot of stress and dismay with their colleagues who are already in it. And so they don't really choose it. So we don't have physicians going into it. We have a lot of physicians retiring early. And then we have this massive aging population coming to the ICU. And so how do we take care of them? And obviously technology is one of the solutions on that. So next slide, please. So the Leapfrog Coalition is a consortium that got together and said, well, how can we reduce the ICU burden for the country? And so they said clearly that you can get the highest grade if you can have an intensivist present in your ICU, an ICU specialist present there for 8 hours a day, 7 days a week. And then during off hours, if they can respond to pages on average within 5 minutes, you get a very high grade. And this is associated with lower lengths of stay, lower mortality. So despite this being around for 20 years, less than half of all US hospitals have this footprint in them. So it's been widely pushed out, but not been able to be successful. And the large reason because of that is lack of physicians. It's not that the idea isn't good or that people won't embrace it. It's just we don't have the staff for it. If we could implement it, we could save as a country $5 billion and save just under 60,000 lives annually. So there's real impetus to do it. There's real good reasons to do it. And if somehow we could use technology to transcend the staffing issue, then we can make up for that gap. Next slide. So tele-ICU, as I mentioned before, tele-ICU is something that came out 20 years ago. Two intensivists from Hopkins actually saw this problem that we were going to have, saw technology as a way to wrap around that and to solve for it. And they implemented tele-ICU. So we now have about 20 years of experience in the United States on tele-ICU. The pandemic obviously brought all this to light, but this is something that had been going on prior to the pandemic. Now we know from the literature that there's really three things that matter in terms of getting the tele-ICU to work well. And they all have to do not with the technology, but really with the people working with the technology. What makes the program a success are really the human interactions around the technology and the change management that occur and the acceptance of it. The barriers to that have gotten a lot less with COVID. There's been much more well-received, broad acceptance of telemedicine than there was in the past. But there have been well-designed studies that looked at the characteristics of successful tele-ICUs. And so we now know those and we can implement those correctly. Next slide. There's really several models of tele-ICU out there, and they're really designed for what the substrate is, what type of hospital needs the tele-ICU care. So the most famous model, and the model that's in probably 95% of all hospitals at this point, is the continuous model. For those of you not familiar with the continuous model, there are physicians sitting in typically a hub, as pictured on the top right. In that hub, they're using software. That software analyzes vital signs, blood pressure, heart rate, respiratory rate, et cetera, and labs and diagnosis and their medications, and runs those data through algorithms. Those algorithms then try to pick up acuity changes on the patient and head off problems. They also have best practice reminders so that complications don't occur. And in that model, a physician can take care of 150 ICU patients, which is a very large number. That model is very expensive, and it works really well. And certainly that was the only model for about the first 15 years. But not every hospital can really afford that or needs that. So on the flip side of that, there is the more episodic or responsive model, in which you really need a cart for telemedicine, and the doctor and the nurse, or the doctor and another doctor, are working over the camera to help take care of a patient, maybe at a rural facility. They then either decide to stabilize that patient and transfer them, or stabilize that patient and keep them. Either way, it's a win for the patient. We'll talk about trying to keep the patient locally and what that means in just a second. But that model is well received at the local level in the more rural and small hospital model. They don't really need all the bells and whistles of the centralized hub. In that model, that can be done in a decentralized location. Often the physician or a clinician can be in their office or at home and not have to come to a centralized hub. Next slide, please. If we look at what's driving adoption, I mean, it's pretty obvious what's driving adoption right now. It's the pandemic. Everybody sees a need to have tele-ICU at this point. But prior to the pandemic, we also knew what was driving adoption. Many healthcare systems would implement it because it increases quality and improves safety. You have an intensivist there 24/7. They can see these patients in real time. They can help, expand the workforce. The other thing that people have often done when they implement telemedicine is really look for care standardization opportunities. Telehealth is a great care standardization tool. You have small groups of clinicians in quiet environments where they're not distracted. They can focus on protocolized care and driving protocol across a wide number of patients, regardless of geography. Other places have done it really just to leverage their staffing. They know that they're going to be short. This is one of the ways to solve. And I'll talk about this at the end, but it can be a great tool for load balancing across a hospital network. So keeping the lower acuity patients at the rural hospitals close to their homes, and then identifying and bringing the high acuity patients to the mothership hospital or the high acuity hospital, so they can get the best care that they need at that time too. Next slide. As I mentioned before, during the pandemic, reimbursement changes have occurred that made telehealth a lot easier to implement and really reduce the barriers. Prior to the pandemic, you could only bill for telemedicine in HRSA-based areas. Now, with the pandemic and hopefully for the foreseeable future, you can bill the patients regardless of geography. This has made tele-ICU adoption a lot easier for hospitals. It reduces the amount of costs needed to implement the tele-ICU, and really has been a real help during this pandemic. Next slide, please. I think probably everybody would say, that's really great to show all this tele-ICU information, but is there any data that actually helps patients? And so the first study that came out, it's about 10 years old now. It was in JAMA, and it looked at implementing a tele-ICU in an academic medical center. They looked at all types of patients, whether they're medical, surgical, or cardiac, and they looked at the data before they implemented the tele-ICU and then after they implemented the tele-ICU. What they found is that the hospital mortality rate for the ICU patients went down by about 70%. Length of stay dropped by a third. Complications went down. Clinician satisfaction went up. All this was done in an academic medical center. And they're really the first study. Now, this study's been replicated at other centers over and over again. I think the most recent study was a 40,000 patient study across 23 states and found almost exactly the same results. So it does have a benefit on length of stay and mortality. Next slide, please. Obviously, cost is a very important feature. Tele-ICUs are not inexpensive to set up. Hospitals want to make sure if they're going to make this investment that they do it and that there's return on investment for them. So this again is an academic medical center. It's actually the same place as the previous study. And they implemented their tele-ICU, and then they did something unusual with it. They really turned it into what's called a logistics center. And in the logistics center, they didn't just get involved with taking care of the ICU patients 24/7. They also viewed themselves as a patient flow mechanism. They were trying to keep some patients local at the local hospital. They were also trying to bring patients through the academic medical center, utilize every bed because, as I mentioned before, the ICU is often a bottleneck, and then use that team to really standardize care and drive down the cost per case. And so if you look to the graph on the right, it really kind of explains everything, but it's really a time-based study. So they had from 2004 to 2006, they had their pre-data where they didn't have a tele-ICU. And then from 2006 to about 2010, they had just their tele-ICU. And so you see in that period, case volume went up, which is linked to revenue typically. Revenue per case went up. And cost per case went up, but it was only because they were building their tele-ICU. As you look at the 2009, that red line, it starts to go down. And that's because they started doing more care standardization. Then they really brought their tele-ICU and changed it into what they called the logistics center. So it did everything the tele-ICU did, but it also got involved with patient flow and more care standardization. And they were able to increase case volume further. They didn't build any more ICU beds, so they're able to increase case volume through that same footprint by about 40% without building a single ICU bed. They were able to drive down cost per case significantly. They actually did 41 care standardization projects during that time, and their revenue maintained. If you look at the bottom line impact for this healthcare system, it was a $50 million contribution margin over about 5 to 10 years. So meaningful impact, good for the patients, good for the clinicians, a win all around, really, for everyone involved. Next slide, please. Here's some work that we did, and I'll try to set this up the right way. So this was a hospital that had recently been acquired by a large healthcare system. And historically, when patients came to this ER of this hospital, they had been transferred out to a competitor of the hospital that just bought them. So not a competitor of us, but a competitor of the hospital that just bought them. And when you talk to the ER physician, you say, why are you transferring all these patients out? They would say, well, there's really some 3 good reasons. Number one, in our intensive care unit, there's no one there at night. We don't have any confidence in the care. We think that there's a lot of complications. We think patients are at risk when we put them in there. Number two, if patients wait in our ER, we're not critical care physicians, we're ER physicians. We get very nervous about taking care of them, and we just want them out of our ER so that we're not responsible for them. They can get the right care. And then number three, that competitor, they have a really easy to use transfer process. It takes us just minutes on the phone to really get an answer. And we said, okay, well, how can we fix that? So the first thing we did, we put teleicu into their ICU 24/7. So they had confidence in their ICU and they could put patients in there. Number two, we put a cart for telemedicine in the ER. And if the ER physician had a critically ill patient, he or she could hit a button on the side of the cart. About 27 seconds on average later, one of our tele-ICU physicians would be there to help them take care of the patient and help them find a bed, more importantly. And then three, we redesigned the transfer process for this hospital system to make it very easy and to make sure the patients got triaged safely. So the right patient got the right care at the right time. And what you see is that the hospital system went from referring out 57% of the cases to keeping 71% of the cases. This is a net average of about 220 cases per year that were staying locally at this hospital. That really meant a lot to the bottom line of that hospital, but it meant more to the patients who didn't have to travel for their care, or their families who didn't have to travel for their care. And if you surveyed the ER physicians at the beginning versus the end, the ER physicians ended up loving the program and really finding it very valuable and helpful. So did the ER nurses, by the way. They had someone to talk to about these patients. They could get instant help on orders, and it really made a difference for everybody in the community. Next slide, please. I'll finish up with, this is sort of the last part about tele-ICU. If you look really at survey studies, and if you go to the American Telemedicine Association and say, I really want to do a survey study about, you name it, tele-ICU, telepsychiatry, tele anything, they'll tell you, well, we don't really need another survey study because there's so many positive survey studies now. Adding one more to the literature won't do anything in terms of changing opinion. So when you survey hospitals, when you survey nurses, doctors, patients, they find telehealth helpful. That's clearly well defined. Rural hospitals particularly find it helpful because it's a way for them to keep their patients in their community. It's also linked to their financial health, and it allows them to also maintain their skills with these critically ill patients. So tele-ICU can be very well accepted in these rural hospitals. And by the way, most of these rural hospitals had to set up some form of telemedicine during the pandemic. Now it really just needs to be reorganized and sort of have best practices implemented and really get the most out of it. If we go to the next slide, I think for some discussion questions. Nicole, did you want me to read these, or do you want to read them?
I can chime in. So our first one is about if tele-ICU support, can tele-ICU support greater equity in care access anywhere?
So I'll take an answer on that one. So the great thing about tele-ICU support is telemedicine in general, is it's a great equalizer. It doesn't matter where the geographic location is, as long as they have access to internet and the hospital can implement that, the patients can get the highest level of care. And really, I think that's what really drives me about telemedicine, is that you can bring care to any patient at any time, regardless of their geography. You can also help them avoid unnecessary transfers and really being away from their families while they're sick. It's a huge burden on the family when they have to be transferred to another hospital. They have to take time off to visit them. They can't see them as often. There's all kinds of data about outcomes associated with that as well, in addition to the cost. So I think, tele-ICU support, it'd be almost impossible to recruit ICU doctors to all these rural locations. But with tele-ICU, that can be done relatively quickly through technology.
Yeah. And all of you out there listening, be thinking about your questions. Definitely, if you have any questions you want to ask, you can throw them into the chat, or as soon as we get through these last couple, definitely feel free to unmute your microphones and ask Dr. Scurlock any questions you have about this. So the next one is, what benefits do care in the community offer for sustainability versus transferring?
Right. So I think, the real answer around this is implementing the tele-ICU and doing it effectively. There is not a one size fits all. You have to really understand what's going on in the local community. Why are they transferring patients? What resource do they need? And how does a tele-ICU help with that? And the example we gave, the ER physicians just didn't have confidence in their own ICU. They were concerned from a patient safety standpoint. That can be bridged relatively easy with tele-ICU. Offering support into the ER can also help, because in the ER is where the decision usually is made to triage. So getting the patient relatively quickly has benefits in terms of length of stay and mortality. We know that, but it also has benefits for reducing transfers that are inappropriate as well.
Mm-hmm. And we heard from another speaker a couple of weeks ago when we were talking about tele-ED, and they were saying very similar things. As it was just a comfort and a relief to have somebody there to back them up after they, were all stressed out from COVID and working too much, or maybe they were brand new providers. Yeah. That speaker talked about helping someone deliver a baby in a rural ED where that's not where you normally deliver babies, and a lot of rural hospitals don't deliver babies anyway. So right. There's definitely a lot to that. So the last one then, how does tele-ICU reduce burnout and support clinical joy in care delivery?
Yeah, and so, that's really, I think, the heart of this and how we get through all this, because there's massive staffing challenges that every hospital is facing. With those staffing challenges are also financial challenges that those encumbers. So tele-ICU can be a great reducer of burnout. One, it can reduce the night burden of the on-site staff. I mean, no one really enjoys working all day and then taking questions and staying up all night and then coming back to work the next day. That is a real recipe for burnout. So you can preserve your local physicians and clinicians, so they're not getting as much night call. Number two, the bedside nurses at night typically are the most junior nurses who are given the sickest patients and have the least resources to access around them. So with a tele-ICU, we've seen reduces in absenteeism, reductions in turnover, and really, that nurse can feel very supported by a tele-ICU clinician, which, by the way, is doing a shift. It can be called 100 times or 5 times, and you're not really waking them up and disturbing them. You're just getting them involved in the care. And so, all of that has reciprocal effects during the day as well, where the patients now aren't as sick during the day, the staff isn't as overburdened, and it's a great bridge for staffing and for burnout reduction.
Great.
I think that's my last slide.
Yeah, I see a hand raised from our participants. Steve Barnett, go ahead.
Hi, thank you. I also have a clinical background in anesthesia as a nurse anesthetist, but I've been serving as a hospital administrator for several years in a rural environment in Michigan. My question, and I'm already on board when it comes to telemedicine. I've been sticking my big toe in whether or not we want to bring this level of telemedicine to our facility. And part of, you've said that it's really taken off with COVID over the last 2 years. How much success have you had handling a really rapidly decompensating patient? Because they come in, they look like maybe they're manageable, but we all know that if we don't get them out of here and they have some certain comorbidities, that they can decompensate very quickly. How are you dealing with that? And have you had that exposure in a rural area?
Sure.
Because you can't get them out now. You can't transfer.
Yeah, no, great question. Always nice to meet a fellow anesthesia person. So, 20%, I'm going to answer this question in multiple layers, and you tell me if I answered you or not at the end. 20% of all US beds are tele-ICU beds at this point. The original segment that was growing the fastest was rural areas. When it started, it was all in rural areas, and that's where the initial wins were. And so a lot of those places had to do with those sick patients that are decompensating quickly. It then moved into the urban environment with large academic centers implementing this and also putting it into the smaller hospitals. If you look at the literature, the patients who benefit the most in terms of reductions in mortality and reduction in length of stay are the patients who they get to quickly that are very sick. We know that if we can get to the patient in less than an hour with the tele-ICU clinicians, there is reductions in length of stay and mortality. For the patient you described, there's multiple benefits if you can get the tele-ICU clinician there. Number one, we can resuscitate them early. And if they do need to be transferred, they're being transferred in a more stable state. And there's actually data looking at when they arrive that their acuity scores are lower if they've been seen by a tele-ICU clinician out in the community. And then number two, if we can resuscitate them and stabilize them, there's potential that they can stay at the local facility. If we do all that, we need to build in workflows for things like central line placement, PICC line placement, midline placement, intubation. All those things have to be there, but we would never go into a telemedicine program without doing that already. So you're thoughtful about all those things, but the patient can benefit if they're transferred. They'll usually typically arrive more stable, and or they can stay there. And I think, as you probably know, all the literature in critical care for sepsis and ARDS is about getting the patient as rapidly as possible, get antibiotics in them, get fluids in them, check their lactic acid, all that kind of stuff. So that's really, you can do all that remotely for the most part.
Thank you.
Sure. Nice to meet you.
Right. Any other questions? I don't see any in the chat.
I wouldn't mind extending with another question if
Sure.
I can go ahead and suck up some more time here.
Sure. Go ahead.
Is well, I've been in South Dakota on a couple of more than one occasion bird hunting, but it's my understanding it's a fair amount of this. Is that really where a lot of this began? Are many of the rural facilities in the Dakotas?
There is certainly, the Dakotas have a presence in telemedicine in general. There are places in the Dakotas that actually started at Hopkins, is where everything generated from. Hopkins and Virginia were the original tele-ICU sites, and that's where it started there. And it did eventually expand to the Dakotas, but it's not where it started.
Okay.
If you go into the history of telemedicine, the first, I think, telemedicine visit was in Logan Airport in Boston, which was between Boston and Mass General. But that was like, a very rudimentary telemedicine experiment. But yeah, it's really the centers of excellence that developed this.
How long does it take to get comfortable with, and we're probably not much different than many. I have it's a low volume ED, less than 10,000 visits a year.
Yep.
So those docs serve as my hospitalist as well.
Yeah.
How long does it take to get comfortable with working with them or them working with you?
Mm-hmm.
And are we seeing different intensivists throughout a 24-hour shift if we had several patients, or how does that work?
Yeah. I'll answer, that's a great question. So most of the intensivists work 12-hour shifts is the way that the typical workload is out there, the EC. And so you'd have typically two. It works the very best as you're getting on is when the two clinicians on both sides are familiar with each other. And so I've always embraced the way of implementing is, hey, we can't put 60 physicians in this small hospital. We need to cordon off 10 or 15 and create a pod of physicians who take care of these particular patients. They know that hospitalist, they know what the hospital can do, what it can't do. They know the nurses, they understand the protocols. They actually understand the strategy of what the hospital is trying to do, whether they're trying to retain cases or trying to build a stroke program. What are they trying to do? That's step one, is getting the physicians familiar with it. On the other part, like how long does it take? I've always embraced change management principles with this and implementing it the right way. And I found that on average, 10 years ago, it was taking about 6 months for people to get comfortable with the idea, concept, and then how to maximally utilize it for the value of the hospital. Post-COVID, I was just working with a small hospital in sort of Western New York the other day. And that's about a 2 to 3 month cycle now. Like people are getting very familiar with it, understand the value. There's these really sick COVID patients everybody is seeing, and everybody understands like, hey, this isn't something for the future. This is the present, even the past, and so I think, it's a pretty rapid implementation and adoption now compared to where it used to be. But you still want to put in some change management principles. You want to look for like early wins. things that we can do together as a team. Let's create a vision together. Let's over communicate that vision as a group. And so, there's always a naysayer in every. I've never gone to a hospital where there's not one person like, I don't like this idea, but usually they can be won over when they start sleeping at night. So.
And then what about credentialing? Do we need to credential everybody, or do you try to narrow that down? Because that like with Nighthawk services, I mean, we'll process several applicants every month, and it's an expense and it's a lot of work.
Mm-hmm. Yeah, I really go against that. So I like a small group of physicians take care of this hospital. It's good on both sides. It's good because it's good for you because you don't have so much expense, cost, and complexity. And it's good for our clinicians because they also don't have to learn another. I mean, like it's not easy to learn this EMR, then learn that EMR, and Bobby over here and Joe over there, and you got to learn the local politics and you got to learn the local people, and you'll get much more results out of that. So I always try to get small groups of clinicians taking care of these places, and I feel like that's where the maximal value is on both sides. Yeah. Well, I've gone into a hospital where they're like, oh, you only have 15 physicians, and Nighthawk just came here and we had 100, or teleradiology group. There's different staffing models.
Right. Well, thank you. And thank you, Nicole, for giving me the opportunity to ask several questions.
Yeah, absolutely. I always like your questions because I think you're bringing the rural hospital perspective to the state flex programs, and that's what they're doing is supporting rural hospitals. So great questions. Thank you. So what we've heard today, and still seeing no questions in the chat, still feel free to jump in and ask questions if you have them, but I'm going to kind of start wrapping us up here. So what we've heard today is about better patient care in different ways, right? Not transferring seriously ill patients is potentially good for their outcome and good for the hospital financially as well. To connect it to the Flex program, though, is through the operational and financial improvement program area of Flex. So activity 2.4 is operational improvement projects. This optional category includes activities to improve CA operations, which may include hospital-wide, department, or service line interventions. These projects should improve efficiency, lower costs, increase patient serve, or otherwise positively impact CA operations. And I think we heard a lot about that with what Dr. Spurlock was telling us about tele-ICU. So that includes training and technical assistance to implement new service lines and expand access to services. Consider too that in a time such as we're in with the COVID pandemic, it might be an identified need across multiple hospitals, which might be not the case outside of a public health emergency like COVID-19. So it's possible that you could cohort hospitals together and work toward implementation and sharing of best practices as they go. So if this is something you might potentially be interested in, talk with your Flex project officer at the Federal Office of Rural Health Policy about details about that initiative.